And I would invite Dr. Rajesh Sinha, and he too will be showcasing us some of the complications coming up.
Thank you, Dr. Priya, for having me in this course. And I'll be talking about a few case scenarios wherein the lens was decentered. I'm sorry.
Thank you.
So, if the lens is decentered, then the visual axis and the optical axis, the central axis of the IOL do not coincide, and that's why there is suboptimal visual acuity. And if the lens is decentered, it can cause a reduction in visual acuity. It can cause other complications like corneal complications. It can cause glaucoma. And the basic idea, the main aim is to recenter the IOL. Now, most of these cases, they are already operated once or twice, and they are complicated scenarios. So the basic idea is that with whatever minimal manipulation you can maintain the centration of IOL, that is the best thing. And if that doesn't work, you can obviously go ahead with a more complicated procedure. So this is a case wherein the lens was, this is a PMMA lens, old, it's a slightly old video, PMMA lens that was there. And you can see here that the capsule is damaged in this area. But this area, the capsule was very much present. So simply you can do a trial of dialing once, which will hardly take 2 minutes. And if you dial the lens and the haptics are on both sides on the capsular support, then it will remain like that. And if it doesn't get decenter after that, there's no problem. Only thing is that when you dial it completely, you remove the viscoelastic completely, because otherwise if there's any retained viscoelastic, there's chance of rotation of the IOL and it will again get decentered. That is one problem. The second issue is, it's a case of again a decentered IOL, a case wherein the corneal perforation repair was done, lens matter aspiration was done. This is the central area wherein the capsule is damaged, and a lens was implanted in the sulcus which got decentered because of the zonular deficiency somewhere here. So I'll just show here that the since the lens is present here and there is an opening here, so you can just bring the lens in the center and capture the optic into this opening. If that is doable, because this is a fibrosed capsule, will remain like that forever, and if you can do the optic capture in such a scenario, then the IOL will also remain well centered always. So only thing is, in a fibrosed capsule, sometimes it is difficult to do optic capture. There is a risk of the capsule getting torn. So you have to be a little extra careful. Then another scenario which I am going to show is, it's a case wherein the IOL was, single piece IOL was placed in the bag. After trauma, the patient had this bag and IOL both coming above the iris. Now, in a traumatic zonular dehiscence, it is a one-time zonular damage. It's not a progressive zonulopathy. So if the damage is somewhat up to here, from here to here, if you just put an endocapsular ring, the remaining zonules will keep it in its position. So this is what is being done. And another thing is that you have to judge when was the surgery done, how much is the capsular fibrosis. If the capsule is fibrosed in the periphery, then in that case you will not be able to put the endocapsular ring. But here the capsule was not fibrosed in the periphery, so an endocapsular ring is being placed. It is, once it's in the bag, it is being pushed, and as it is being pushed, it comes in this area, it brings the bag posteriorly, and the bag IOL complex goes behind, and once it is in the center, it will remain there in its position, and touch with the patient is still having a centered, well centered IOL. But another scenario wherein the lens in the bag has got decentered so badly that you cannot just use an endocapsular ring. This bag is also fibrosed, and plus this decentration is too high. So in such a scenario, it is better to fix the IOL, fix the haptic. So without doing much manipulation, you can simply pass lasso suture around the haptic here, and you can fix this haptic in this position. So you just create a groove at about 2 millimeter position, 2 millimeter from the limbus, and then a 9O proline suture needle is passed. This patient had asteroid hallosis. So whenever while manipulation, if vitreous comes into anterior chamber, you should always do a vitrectomy. Never manipulate when the vitreous is in anterior chamber, otherwise it will cause traction. So this patient had asteroid hallosis, so I didn't have to stain the vitreous whenever the vitreous came into anterior chamber. Like after this manipulation, some of the vitreous came from here. So then it requires a vitrectomy. So just take out the needle, and then you can do a vitrectomy in the anterior chamber and clear it up. Now it has been cleared, and now again you can manipulate. So uh, a lasso, a loop around the haptic, you pull it and then tie knot, and you can see that the lens is well centered. So this is again a procedure wherein minimal manipulation has been done, and the lens with the bag is well centered. This is another scenario wherein the lens, a multi-piece lens, is somehow there in its position. There is no capsule visible. It is getting caught. It is caught in the uveal tissue, I guess. And the patient had a recurrent uveitis glaucoma, and the patient had a lot of symptoms. So initially, the patient was given steroid. I didn't want to handle it because it was stuck. But then after removing steroid, again the patient had this problem. So this lens was re-inverted. One instrument is placed behind the IOL and another above, and then you take out one haptic, so that when one haptic is out, then it will not fall behind. And then with the lens fixing forceps, you hold the tip of the haptic, exteriorize it, and then you can do a glued IOL and exteriorize both the haptics, tuck it into the groove made adjacent to the flap, and then once the lens is properly in position and not inverted, then the patient was not having any such symptom. Sometimes you do this glued IOL, and this patient had a glued IOL done by one of my residents. Somehow I feel this haptic got slipped. This usually happens if you create a small groove here, or the tucking has not been done properly. So in that case, since here it was well tucked, but here it was not, so a fresh flap and a groove was created, and the tip of the haptic was held, and it is exteriorized, and once it was exteriorized, it was tucked into the groove, and with the help of glue, it was brought, and the flap was repositioned. Another scenario or case wherein another old case wherein the lens with the capsule was hanging into the vitreous cavity. It was a vitrectomized eye. So since it was hanging in the vitreous cavity, endoilluminator was used to lift this IOL above, and once it was brought in position, then lasso suture was placed around both the haptics. On one haptic it was being placed. The lens was supported with the help of endoilluminator. The endoilluminator was used because you can see the surrounding area as well, so you don't damage the surrounding area. And then on both sides the lasso suture was placed, and the IOL remained in position. Many times these decentered IOLs, they cause glaucoma, they cause endothelial decompensation, and this is a case wherein decentered IOL was causing endothelial decompensation. So we planned for glued IOL with ultra-thin DSEC, and this is how the DSEC lenticule was created. And sclera was marked at 1.5 and 3 millimeter positions, and then the lamellar dissection was done to create a groove and a flap. Epithelium was debrided, and then with the help of reverse Sinski, the desmase was stripped off. Then the decentered IOL was taken out. It was an anterior chamber IOL which was partly touching the endothelium, so it was taken out. And then intrascleral haptic fixation was done. It's a multi-piece IOL which is being used. and it is tucked into the groove, and then this DSEC lenticule is being introduced, and so it not only provides a centered IOL but also provides improves the clarity of cornea. And what I have felt so far is that even with the PMMA haptic, when you are doing a glued IOL technique, you don't have any kink or any problem. But when you are doing Yamane, it creates a problem. So I'm using some PVDF haptic lens. There is another Indian company also that is also making, Freedom is making IOL with PVDF haptics. So with the Yamane technique, you use PVDF haptics IOL, then it works very well. With PMMA haptics in Yamane, it doesn't form nice flange also. A better flange is formed with the help of PVDF haptic. But with when you are doing a glued IOL, it is, maybe with practice or whatever, there's no problem when you're using a PMMA haptic. So thank you very much. Just wanted to show a few cases. Thank you once again for the opportunity.
So excellent, excellent cases. So, sir, the last case where you combined the IOL explant, intrascleral, and the DSEC, do you find that in such eyes with relative hypertony, with so much of surgery, that the DSEC quite often detaches very quickly? And would you consider doing it in a two-staged manner a few months later?
This is a very good question. The same thing was there in my mind, and that's why we did a comparative study between two-stage and a single-stage ultra thin DSEC with glued IOL, and this was published in JCRS in the year 2020. That the stage technique has a better outcome because and the chance of rebubbling is also minimal. So definitely, I completely agree with you. This is published there in JCRS June, I think, in 2020. It was published that the stage technique, two-stage technique, is better than a single-stage technique. Another thing, if in such cases, if there is a hypotony, you have to do a even if you are stage, sometimes there is hypotony and there is risk of detachment of the DSEC lenticule. So in such cases, you can do introduce a technique of PISC, that is pars plana fluid injection. Okay. So inject BSS from the pars plana, so that what happens normally in these cases, that there is a tendency for the air to go behind. So when you because of the hypotony, so if you at the end of the procedure, from 3 millimeter, you go into the mid-vitreous, inject some fluid, so it pushes the air anteriorly, and plus it reduces hypotony also. It works very well so far. I have done in 14 eyes. We are just sending for publication, and none of the eyes required a rebubbling. No, no, not really, because most of these patients are many times they are partly vitrectomized, and if the air is going behind, obviously there is a space there, and so you don't have to inject too much. Inject little bit of fluid so that the fluid covers that space that is being occupied by the air. It pushes the air, and as the air comes anteriorly, you will see that the lenticule becomes a little more bright and tense, and that is the end point. You don't have to inject too much. Because if you do a vitrectomy further, again there is risk of further, there's risk of hypotony, risk of detachment of lenticule. On the day of surgery, you can still see that the lenticule is attached, but if you see use a microscope integrated OCT, but next day, because of hypotony, it detaches. So that's why if you inject fluid, so far in 14 eyes, we have seen that none of the eyes required any rebubbling. Yeah.
And sir, in such eyes, do you tend to choose a slightly smaller graft for DSEC compared to normal eyes?
It again depends on the white to white, and also depends on whether the iris is stuck up in the periphery or not. If it is a large white to white, then you can have 8 millimeter lenticule. But if it's slightly smaller, multiple times surgery done, slightly inflamed looking, iris slightly having pass and stuck up, then you would rather go for a 7.5 millimeters.
Thank you so much, Dr. Rajesh Sinha, for being